Hello everyone and welcome back to our channel Anesthesia and Critical Care Medicine, that stands for AACCM. In the previous lecture, we had dealt about what are the causes and how to diagnose a primary defect in the ABG analysis. Myself, Dr. Sahil Gupta, I am working as an associate consultant in the field of critical care medicine, and I'll be taking you through in today's lecture, that is metabolic acidosis. Now, the metabolic acidosis can be diagnosed in an ABG by the fall in bicarbonate values. Now, it can be due to three reasons. The first, it can be due to increase in the acid production in the body. Second, it can be due to loss of bicarbonates from the body. And third, it can be due to a renal pathology compromising the situation where there is an inability to excrete more of acid from the body. So, once we have diagnosed that the primary defect is metabolic acidosis, and in the step 3, once we have seen whether there is compensation or not, we have to further substantiate our points in the APG analysis by calculating something called anion gap. Now, what do I mean by the term called anion gap? Anion gap stands for the measured difference between the measured cations as well as the measured anions. Now, as we all know that to maintain the isoelectric neutrality in the body, the total number of cations should be equal to the total number of anions. Now, if we see this is a cell, the predominant cation in the body are sodium and potassium. Now there are then the predominant anions in the body are chloride and bicarbonate. Now we have to remember that there are unmeasured cations as well as anions in the body, which can be calcium, magnesium, inorganic plus organic anions, phosphate and sulfates. Now how to calculate the anion gap? It is calculated by a very simple formula, which is the difference between the cations and the anions. Now the difference lies here whether we take potassium into account or not. Okay, so if we take the potassium into account, the normal value is around 16, and if we don't take potassium into account, the normal value is around 10 to 12. Now once we have seen whether the patient is having a normal anion gap, high anion gap, or low anion gap, in a case of metabolic acidosis, we can see that there are different situations which can contribute to all of these. Now, for a high anion gap metabolic acidosis, the mnemonic can be remembered as CAT mud piles, which stands for carbon monoxide, aminoglycosides, theophylline, methanol poisoning, uremia, diabetic ketoacidosis, paraldehyde, isoniazid, lactic acidosis, ethanol, salicylates. There is another mnemonic to remember this, which is CULT, KULT, which stands for ketoacidosis, uremia, lactic acidosis, and toxins. Okay. Now, what are the reasons for high anion gap metabolic acidosis? Now, the anion gap is affected by changes in the unmeasured anions. So, let's take an example of diabetes. Okay. Now, if the patient is having an uncontrolled diabetes, there is an increase in the ketoacidosis due to metabolism of ketones. Now, due to the raised levels of acid which binds to bicarbonate, there is a buffering effect to form H2CO3. Okay, so there is an increased use of bicarbonate to act as a buffer. So the bicarbonate level decreases here, which causes metabolic acidosis plus high anion gap. Now, if we remember this formula, if Here, the bicarbonate level falls, the anion gap will increase. So, this is a simple example which happens in a case of diabetic ketoacidosis. I hope I am clear till now. Now, coming to the second point, that is normal anion gap metabolic acidosis. Again, there is a mnemonic to remember the different causes of normal anion gap metabolic acidosis, which is fused cars, which stands for fistulas, U for ureteroenterotomies, saline administration, endocrine abnormalities like hyperparathyroidism, diarrhea, carbonic anhydrase inhibitors, ammonium chloride, renal tubular acidosis, and drugs like spironolactone. Here, the normal value of the anion gap, sorry, will be 10 to 12, depending upon whether we are taking potassium into consideration or not. Coming to the third, that is low anion gap metabolic acidosis. The causes here are very less. The most common cause here is hypoalbuminemia. Now we have to remember that because albumin is a major anion in the body that is negatively charged, the fall in the albumin level has a direct effect on the calculation of anion gap. So which brings to the next topic, that is corrected anion gap, which can again be calculated by a very simple formula, that is observed anion gap plus 2.5 into the normal albumin minus the observed albumin. The normal albumin here is taken as 4.4. So once we, to remember this, once we have diagnosed that the patient is having low anion gap metabolic acidosis, that is less than 10 in the anion gap, we have to see whether albumin is contributing to that picture or not. And if for that we have to calculate the corrected anion gap, and if the corrected anion gap comes out to be a different from the calculated anion gap, then albumin is the culprit here. The other causes of low anion gap metabolic acidosis are spurious hyperchloremia, bromide intoxication, spurious hyponatremia, and hypermagnesemia. So I hope I'm clear till now that once we have diagnosed a case of metabolic acidosis, we have to further see the anion gap. Okay. Now there is one more point. In a case of normal anion gap metabolic acidosis, we have to find something called urinary anion gap. So what do I mean by urinary anion gap is again the difference between the anions in the urine. The normal anion gap is the difference in the serum, and here we are taking it as urine. So we have to calculate what is the urine anion gap. Okay, so usually the urine anion gap is negative because of the ammonium excretion from the body. If it is positive, we have to see the pH and the plasma potassium, which will help us to differ between the different types of RTAs. So that is a separate algorithm to differentiate between RTAs. Okay, so if the urine pH is greater than 5.5 and the potassium is normal, it is distal RTA. And if the urine pH is less than 5.5 with a high potassium, it is type 4 RTA. Okay, so shall we go to the next point? Now, the next step is to calculate the delta gap. Now, the delta gap is the difference between the actual anion gap minus 12 plus the bicarbonate levels. If the delta gap is greater than 30, there is an additional metabolic alkalosis. We will see it how. If the delta gap is less than 18, there is additional non-gap metabolic acidosis. And if the delta gap is between 18 to 30, there is no additional metabolic disorders. I know that it's getting little difficult, but trust me, it's not. Let's come to the last part, that is step 7, which is delta ratio. Now, the delta ratio is the difference between the anion gap divided by the delta change in the bicarbonate levels. So, writing it as the formula, the delta ratio is the anion gap minus the normal anion gap divided by the normal bicarbonate minus the measured bicarbonates. So, delta change in the anion gap divided by delta change in the bicarbonate. Okay, again, the normal anion gap is taken as 11. The normal bicarbonate is taken as 24. So, there is another formula, that is calculated anion gap minus 11 divided by 24 minus bicarbonates. So that stands for delta ratio. Now, what is the significance of delta ratio? If the delta ratio is less than 0.4, okay, so it stands for non-anion gap metabolic acidosis, or let's write it here. If the delta ratio is less than 0.4, there is pure non-anion gap metabolic acidosis, that is NAGMA. If the delta ratio is between 0.4 to 0.8, there is mixed normal anion gap metabolic acidosis plus high anion gap metabolic acidosis. If the delta ratio is between 0.8 to 2, there is pure high anion gap metabolic acidosis. And if the delta ratio is greater than 2, there is mixed high anion gap metabolic acidosis plus metabolic alkalosis. Relax, guys, we'll be taking it one by one. Now, let's take the first example, that is normal anion gap metabolic acidosis. Okay, so let's say, coming back to the formula, let's say the calculated anion gap here is 12. The normal is taken as 11. The bicarbonates is again normal. So the ratio here will be less than 0.4, or it will be more close to 0. So there is no mixed disorder here, and the diagnosis is only normal anion gap metabolic acidosis because there is no change in the bicarbonate values. Okay, coming to the second point, that is if the ratio is 0.4 to zero point 0.8, there is usually a combination of high anion gap metabolic acidosis plus normal anion gap metabolic acidosis. Now, the mnemonic again could be remembered as cult or mud piles. And the most common culprit here will be the increase in the lactate levels. Coming to the last result, that is if the patient is having mixed, if the ratio is greater than 2, the patient is having high anion gap metabolic acidosis plus metabolic alkalosis. This usually happens in a picture of COPD. Now, just imagine that the patient is having COPD, that is chronic obstructive pulmonary disease, and the patient can't breathe out carbon dioxide due to poor lung function. They will have respiratory acidosis. Okay, but to counteract that, they will have metabolic alkalosis due to compensation. So they will already be having high levels of bicarbonate in the body. Okay, now, or there can be, now if this patient develops a metabolic acidosis, okay, there will be only a slight change from the normal values. Now imagine that the bicarbonate values in the body are already 32. The patient is having metabolic acidosis as the primary defect, so the bicarbonate level will fall to say 28, but it will already be showing a metabolic component, that is metabolic alkalosis. Are you getting it? Just imagine that the bicarbonate level is 32 and that is showing a component called metabolic alkalosis due to COPD, which is again a compensation phenomenon. Now this patient develops the primary defect as metabolic acidosis, so the bicarbonate levels should fall. But for us, the bicarbonate level will not fall below 20. So the patient is having metabolic acidosis plus metabolic alkalosis, so it's a mixed disorder which can be calculated by delta ratio. And if the delta ratio is greater than 2, it will show metabolic acidosis plus metabolic alkalosis. Okay, so this is a use of delta ratio to diagnose mixed disorders. Sorry for that. So, summarizing in today's lecture, once we have diagnosed metabolic acidosis, we have to see the anion gap. If the anion gap is high, normal, or low, if the anion gap is normal, we have to see the we have to see the urinary anion gap to differentiate between different types of RTAs depending upon pH and potassium values. If the anion gap is high, we have to remember it as mnemonic, and if the anion gap is low, we have to see the albumin and we have to calculate the corrected anion gap. Okay, this is step 4. Once we have diagnosed an ion gap, we have to see what is the delta ratio. And if the delta ratio is less than 0.4, it is normal anion gap metabolic acidosis. If the delta ratio is 0.4 to 0.8, it is normal anion gap metabolic acidosis plus high anion gap metabolic acidosis. If the delta ratio is between 0.8 to 2, it is pure high anion gap metabolic acidosis. And if the ratio is greater than 2, it is high anion gap metabolic acidosis plus metabolic alkalosis. To remember it is in a very simple way, there is only one normal anion gap metabolic acidosis, and in rest there is high anion gap metabolic acidosis. Okay, so I hope I have made myself clear in today's lecture. Please subscribe to our channel, show us some love, because we are taking a lot of efforts to make these PPTs and presentations, and please share it with your colleagues. Subscribe to the bell icon and subscribe to our channel. Thank you. And in the next lecture, we will be taking more lectures on electrolytes. Thank you.